se. It's really more health economics and outcomes research, which really is evidence development in support of reimbursement. And without that evidence, the reimbursement is really somewhat impossible, if you will. Okay, this is always fun. Cuts off part of the wording. The objectives here are to provide a very basic understanding of the structure of the US healthcare system. And you think, well, I already know the US healthcare system. But as you can imagine, it's very complex, it's very fragmented. And as a result, really is a complex reimbursement milieu in the United States. We don't have single payer here, as you know. And so it really makes for a lot of problems in terms of what kind of coding to use and, how the regulatory pathways affect reimbursement, how does coverage coding and payment affect reimbursement. And so we're going to try to talk about these issues, and I'm hoping to give you some practical applications of these. These aren't just pie in the sky ideas, but I've actually used them in my own life. And I will mention that to you. And don't despair if you've had problems in your own lives in terms of reimbursement, because I do have some anecdotes that might help you with that. So again, health economics and outcomes research really develops evidence in support of reimbursement. The first important concept here is unmet need. You're always hoping to not have a disease, an agent in search of a disease or condition, a technology, but you're hoping the opposite, that you've been able to demonstrate an unmet need for a condition or disease state that your technology will facilitate. And if you're fortunate, people have done this for you. They've already demonstrated unmet need in the published literature. If not, you may have to do a retrospective database analysis. I just published one in Parkinson's disease, and it's in Pharmacoeconomics Open using Medicare data. And there are a bunch of different types of databases, and none of which are that inexpensive. So, but it's really important to justify your technology demonstrating unmet need. How do you plan to quantify the improvement in health outcomes that you hope your technology will demonstrate? Is this via resource use, improved quality of life? How will you generate this evidence? And when will it be generated? Will you wait until your advisory panelists say, that's great that you're expecting FDA approval for your drug or FDA clearance for your device? By the way, never say that a device is approved. It's always cleared in the US. It's just convention. That's the fastest way for investors to know that you don't know what you're talking about. If you talk about device approval rather than device clearance. But it's important, rather than waiting until the last second, you're ready to launch, and now that's great, and now you're going to get reimbursement, no problem. Or you already have a code, no problem at all. Well, just because you have a code doesn't mean the healthcare system is going to reimburse you, and certainly not necessarily at an adequate level to cover your costs and then some. So it's important to generate this evidence all along the way, starting with that unmet need, and in early clinical trials, certainly in phase 2B and 3 clinical trials, putting these types of data variables on resource use. And by that, I mean clinic visits, especially unexpected clinic visits, hospitalizations, readmissions, and quality of life parameters. Embed those into your clinical trials so that you have those data available to you even before launch. Is there a quality of life component to your technology? Do you expect to use quality of life? Particularly, the FDA does this for drugs, for indications for oncology agents. Who or what will be the focus of your sales pitch? Will the buyers be the actual users? Hospital administrators, will there be key opinion leaders involved? I urge you to get KOLs, key opinion leaders, involved very early to support your technology, to help you determine what should be your target product profile. Your TPP is basically your wish list. How do you want people to view your technology, and what attributes do you expect your technology to have? You will develop evidence to be able to attribute these values to your technology, and this will help you generate your value proposition. And lastly, in terms of HEOR, if you plan to try for reimbursement outside of the US, do you have plans for modeling? Cost effectiveness analyses in particular are required in many countries outside of the US to support reimbursement. So let's talk about the US healthcare system. Unfortunately, you can see over on the right-hand side here, and hopefully you can see my cursor, we're not very efficient in the US in terms of healthcare spending, improving life expectancy. We're kind of in the third world country division of the world in terms of the amount of money that we spend on healthcare and our average lifespan of about 80 years. Maybe we're around Turkey, Croatia, Poland, certainly not where France, the UK, Italy, Japan, and even Chile and Costa Rica. I mean, and I update these figures every year. It demonstrates that we really have a long way to go in the United States in terms of our spend and improvement of life expectancy. We've realized for many years, and people have been talking about this for a long time, that we spend so much and really don't get a huge return on our investment that we have to rein in spending somehow. It's been discussed even most recently during this administration about repealing the ACA, the Affordable Care Act, to reduce federal Medicaid spending, but then you increase the spend somewhere else. There are prospective payment models, such as accountable care organizations or ACOs that we'll talk about later, to better align reimbursement to patient outcomes. There is, good for my area of specialization, HEOR, an increasing focus by payers on health economics and cost effectiveness to try to rein in costs. And there have been various proposals to reduce drug spend. An area that's near and dear to my heart is being able to negotiate drug prices for Medicare. I think that should have been never an issue for a long time. But that is actually being done now via the IRA, the Inflation Reduction Act. You can see on this graphic that employer-based insurance, it's mostly commercial insurance, makes up about half of the different types of payment mechanisms in the US, followed by Medicaid about 20% or so, Medicare 15%, and then others. Medicare is the federal health insurance program for people 65 or older and certain younger people with disabilities. It was the first program to actually bundle care for end-stage renal disease. There are 4 parts. Part A is hospital insurance, covers inpatient hospital stays, skilled nursing facility care, some home health. Part B, medical insurance, covers inpatient hospital stays, skilled nursing facility, outpatient care, medical supplies and preventive services. Part C, Medicare Advantage, is basically HMO, if you will. Where parts A and B are administered by commercial payers. United Healthcare is a big one, as is Humana. And Part D, since 1965, has been prescription drug coverage. Problem with prescription drug coverage, although it's really been a boon to many seniors, is that there are about 30 different drug plans. And come around October, you have to decide if your plan still covers the majority of the medications that you take. A lot of seniors do have multiple chronic conditions and take a lot of chronic medications. So imagine, and I'm in this field, and I have to help my mom navigate this every year. And I say, you know what? Stick with what you've got. It's close enough. It pretty much covers what you have. And there's about a 50-50 split between fee-for-service and Medicare Advantage. Until recently, Medicare Advantage payments have really been, coverage has been going up. But it's really kind of leveled off now, especially as we've noted that although it was developed to try to rein in costs, it really hasn't done a great job of that. If you have an elderly parent or relative who talks about, should I switch from traditional Medicare to Medicare Advantage? Robert Wagner is telling me on the commercial or some aging star that I should switch to Medicare Advantage. And I get rides to doctor visits, and I get free dental care and eye care and all these other great things. What they don't tell you, and this really is a shame, it should be at least in the fine print, if not somewhere, you also may not have access to your current doctors. So let's say you've got a cardiovascular condition, you've been well covered and you've been happy with your cardiologist. Well, all of a sudden, he's not in your health plan if you're in Medicare Advantage. So now you have to switch. And this is one of the reasons I told my mom, you know what, just stay with what you've got and traditional Medicare. Once you switch, you may not be able to switch back. Now, even though she knows to talk to me about this before she does anything, she was so excited when somebody called her that she said, okay, I'll switch to Medicare Advantage. And then she thought better of it, called me, and I said, Mom, what did you do? What did you do? I called them back and I said, she really didn't know what she was doing, and you need to switch us back. And I was able to do that, but I do tell you, it was not without some hassles. So definitely be cautious if you're advising or you yourself are even considering if you're at that stage of life, Medicare Advantage. If you've got a chronic condition, it may not be the best for you. Medicare does currently insure more than 67 million Americans, about 20% of the total population in the US. And I told you that there's about a 50-50 split between fee-for-service and Medicare Advantage. There are two different kinds of coverage policies: national coverage determinations, or NCDs, and local coverage determinations, LCDs. You might think that you would want your technology covered under a national coverage determination. And why would I go to individual regional payers and or claims processors when I can just do this nationally? The problem is, if you're turned down, if you don't get the coverage that you seek nationally, it's going to be more difficult to now go back to these local administrators called MACs, Medicare Administrative Contractors, MACs, and try to get them to cover your technology individually. So MACs process claims, define parameters for coverage, and set payment rates according to localized sectors in the US. And here you can see for Medicare Parts A and B that you have 12 jurisdictions, those are the colors, that are administered by 8 MACs, Medicare Administrative Contractors. And what's a little confusing at first glance is you're seeing, okay, well, here's Noridian and here's Noridian. Why are they two different colors? Again, because these are geographic regions and they've been determined somehow. One of the interesting points here is that not all MACs are created equal. There are some that are more influential than others, and their coverage decisions really tend to dictate what the other MACs will do. One of the most influential, if not the most influential MAC is called Palmetto in this area here. And you think it's kind of interesting that Palmetto really just covers basically the Mid-Atlantic region and the Southeast. Geographically, it's not huge. However, Palmetto is the key US CMS, and of course, CMS stands for Centers for Medicare and Medicaid Services. It's the key US CMS contractor for what's called PDAC, Pricing, Data Analysis, and Coding, PDAC, which is used to secure US reimbursement codes. So this bears repeating that Palmetto is the key US CMS MAC for pricing, data analysis, and coding, and therefore does carry an outsized influence on what technologies are covered. So whatever Palmetto says, the rest of the MACs, it sounds like E.F. Hutton, if you remember the old commercials, when what Palmetto says, everybody else listens to. To make matters more complicated, there are some of the same MACs, but depending on what's being covered, the previous one that I showed you was Medicare Parts A and B. This is durable medical equipment. And DME actually only has two MACs to cover all of these regions, Noridian and Cigna. Molecular diagnostics, sometimes people call them MolDX, used to have their own MACs, but now they're actually covered by the same MACs that are Medicare A and B and DME. Okay, so really that's Medicare. Now remember, that's a federally administered program. Medicaid is jointly funded by the Fed and the states. It's for eligible low-income adults, children, pregnant women, elderly adults. Now here you see that there's a crossover between Medicare and Medicaid, and indeed, some patients are considered dually eligible. They're eligible for both Medicare, and if they're low income, Medicaid as well. One usually predominates, often Medicare, and then supplemented by Medicaid if required, and then some people with disabilities. Because there are 50 states, we have 50 different flavors of Medicaid. And this is a problem. Not only do you have 50 different flavors according to the states, but the services from each state, each jurisdiction within a state, even county to county, you go across a county line and you may have completely different services covered. There are core services that are required to be covered, but the ACA allowed individual states the option of whether or not to expand Medicaid to individuals at 133% below the FPL, the federal poverty line. One of the things the ACA did that was tremendous, and I hope never goes away, is it eliminated the allowance of insurance companies to not have to cover pre-existing conditions. So if you had cancer, they'd say, well, that was pre-existing. I don't have to cover it now. That is not the case and has not been since the ACA was passed. So that has really been one of the major positive points of the ACA. Under the ACA, 30 states chose to expand Medicaid, and they added 17 million previously uninsured Americans to the program. We went from a country of approximately 30% of the population being uninsured to about 8% today. I'm really afraid that this is going to now go up with Medicaid requirements becoming much more stringent. So 30 states chose to expand Medicaid. 20 states chose not to expand Medicaid because of various budgetary concerns. As of April 2024, 89 million people, about 26% of the US population, were covered by Medicaid. Now, you can see that about 8 years prior, so 2017, there were about 20 million fewer patients on Medicaid. What happened in the US between 2020 and 2024 that really swelled the Medicaid population? Anybody? Call out? COVID? COVID was largely covered by Medicaid and really saved a lot of people's lives. Medicaid did because of the coverage. Before the ACA, the federal government shared Medicaid costs with the individual states, where the government paid about 57% of the total amount. Over the years, this has slowly been increasing to the point where the federal government now covers about 90% of the costs, and the states cover 10%. So we talked about Medicare and Medicaid. How about commercial payers? I said that about 49% of people in the US are covered commercially. There's about a 50-50 split, with slightly more than 50% covered by Blue Cross Blue Shield and then not. There's about a 50-50 split national insurers versus regional insurers. And you have about approximately 180 million covered commercial lives that are managed under, and again, this is why there's such a mess in the United States in terms of insurance, 5,500 different commercial plans. I mentioned that Blue Cross Blue Shield, although it's a pretty much a 50-50 split, still has the majority of these. There's been a lot of consolidation in the Blues nationally. And one of the things that you're thinking, well, where do I start then? If I'm trying to figure out what kind of coverage I can expect for my technology. One of the things I suggest to people is that they do a commercial coverage landscape analysis of the top 25 payers. So here are the top 25 payers. I believe you're going to get these slides afterwards. And I really redid this year just to try to get this pretty much right. You do have some, as I mentioned, nationwide insurers that cover a lot of the people. Aetna being probably the top commercial insurer. And you've got what used to be Anthem Blue Cross Blue Shield, Cigna. There are a few others. And then there are a lot of the regional ones in the orange here, and hopefully you're seeing orange like I'm seeing orange, are all the individual state Blues, so Blue Cross Blue Shield. The Blues in particular tend to require the highest degree of evidence for coverage. And you'd be surprised that you can Google what kind of coverage and what's the coverage policy from, let's say, Blue Cross Blue Shield for California. So, of course, some of the bigger states have some of the bigger Blues plans, California, Texas, Florida. What's the coverage policy for my particular technology or something close to my technology? And it will often be available to you. It's worthwhile to do that to get a general idea of what are the treatment guidelines that they're citing, what's the published literature that they're citing in support of their coverage policy, what are the lab tests and what values will they cover? Somebody with the disease state that your technology affects, influences. And it's really worthwhile to just Google this. And now it doesn't have to be Google. You can use an LLM. You can use agentic AI. There's a lot of things that you can use But again, as you know, and I think the previous speaker probably talked about this, you still have to be very careful with AI. It does hallucinate. It makes things up. I was in the Miami airport recently and I thought, oh, well, Chase is going to have a lounge here. I wonder if they have a lounge. And one of the LLMs said, oh, yeah, there's been a lounge here. It's between terminals D and E. And it's been here since February. There was no such lounge. It was the Turkish Airlines lounge. It made it up. So you have to be really careful using this. I think that AI definitely has a role in coalescing existing information and make sure that whatever LLM you use or agentic AI you use gives you references and that you check the references. This is probably not this is way outside of this talk, but I can just tell you I use these things all the time and I have been surprised in a number of ways and not happily surprised at what I found. And then lastly, in terms of the healthcare system, are the accountable care organizations. And these are groups of physicians and or hospitals that voluntarily assume the quality and cost of healthcare for a defined population of patients. So for example, let's say you're a cardiologist and you cover a certain number of, and many of these are Medicare patients. About 61% are Medicare, 29% are commercially covered. So you think, oh, well, I'm just going to worry about this person's cardiovascular care. Well, if you're part of an ACO, accountable care organization, you actually have to worry about all of this patient's chronic conditions, their diabetes, the interplay amongst them, and how you can improve patient outcome while minimizing costs. And you can see that over time, the number of ACOs, which is this orange outline, the growth of ACOs, right, the number of ACOs, and then the number of covered lives have increased, leveled off a little bit. And then last I read was in 2024, there was actually quite a boom in ACOs, and there were about 1,800 total ACOs in the US. So I actually only have one slide on regulatory requirements, because then I want to get into coverage coding and payment, which is really the crux of a lot of this. The most important factor in payers' determination of how to reimburse a technology is not the center in which it's being evaluated, CBER or CDRH, but instead it's regulatory pathway. So for example, is it a 510K? Meaning, is there a predicate? So you've got a technology that's very similar to yours and you can basically piggyback onto that technology. Or is this going to be a de novo regulatory pathway? The advantage of the 510K is it's faster, it's less expensive, but you might be stuck with the reimbursement from that predicate. The de novo pathway is more lengthy, it's more expensive because it's more lengthy and requires more evidence development typically than does a 510K pathway. But the reimbursement possibilities are often greater with a de novo pathway. So let's really talk about coverage coding and payment. There are an awful lot of reimbursement codes in the US, starting with CPT codes, HCPCS codes, which are inpatient and outpatient, and then the DRG codes that I'm sure you're familiar with, ICD-9, ICD-10, and then since 2022, ICD-11 codes, which are inpatient only. You can see that they're administered by different bodies, the AMA, CMS, the CDC, and they have different code structures. To make matters more complicated, there are 3 different kinds of CPT codes. Category 3 is that scary word, experimental. As soon as you hear experimental, chances are pretty high that the insurer will not cover it. Oh, it's experimental. We can't cover that. But this is often the category that you end up with when you are first looking to get your technology covered or reimbursed. And then you're hoping to generate a substantial amount of evidence such that ultimately you can be a category 1 that insurers do generally cover. There's a whole pathway to getting coverage, getting a reimbursement code, and then being covered. As I mentioned before, KOLs are really important, key opinion leaders, and especially those that may be influential within specialty societies, which are really very important towards approving your reimbursement code and coverage. CMS does have a Medicare physician fee schedule that lists physician payment rates by CPT code, but these rates differ by setting of care. So there's facility and non-facility codes. Facilities are hospitals, surgery centers, nursing homes, nursing facilities, and then non-facility refers to physician offices. And the reason why we care about that is that reimbursement often differs by setting of care, and even by how long of a stay. Inpatient hospital is greater than 2 midnight stays. I don't know where they came up with these things. Outpatient hospital is less than 2 midnight stays. DME, durable medical equipment, and then lab diagnostics. And you can see one of the areas that's important to note is if payment is bundled or not. We had spoken about fee for service, and you think, oh, I just say that this is my technology, and I go to a hospital and I show you what my value proposition is, and it's great, and all this evidence that I've demonstrated to show that it improves patient outcomes, and et cetera. And of course, you're going to reimburse for my technology, and you're going to use it in your healthcare setting. Well, hospitals typically are under DRGs. These are bundled payments. Bundled meaning, according to this MSDRG, and MS is severity, Medicare severity diagnosis related groups, meaning that they have one bundle to pay for this DRG, this patient's hospital stay. And your technology needs to fit in there. And you need to demonstrate that there are advantages to your technology. Why should this be incorporated into this single bundled payment that the hospital is basically stuck with? Well, you're going to demonstrate that you don't end up in the ICU, or you step down quickly from the ICU to the regular floor, or you're discharged more quickly, or you're not readmitted as frequently. So you need to demonstrate to the hospital that it is worthwhile for them to cover your technology within this bundled payment. Okay, I think I'm doing pretty well here. There is a big interplay amongst different reimbursement components, and we call this the market access cascade of national and state legislation that influences payer benefit design, which then influences coding, coverage, and payment, which will influence your clinical positioning, help you establish your value proposition, which means now this will be your evidence base that going backwards will help you establish your value proposition that will be influential on your clinical positioning, influence your coverage, coding, and payment, and then further influence your ability to get the amount of money for your technology that you need to cover. And we'll go back to coding, coverage, and payment in a second, because if you get nothing else out of this whole talk, coding, coverage, and payment. Really important concepts. But another concept that's important that people are maybe less familiar with, and this only applies to tests or devices and not drugs, is called clinical utility. Clinical utility encompasses improved patient outcomes to a very great extent. And you may not know this right off the bat, but if you can demonstrate that you expect your technology to, as I had mentioned before, when with the inpatient example, reduce hospital readmission, length of stay, improve patient morbidity and mortality, improve patient functional outcomes, such as activities of daily living, ADLs, patient-reported outcomes, and patient burden, or really demonstrate improved patient outcomes, as I said before, either using randomized controlled trials or observational studies. This will help to demonstrate the value-based reimbursement to many of the insurers for tests or devices. So here we come to the all-important coding, coverage, and payment. In terms of coding, are there specific codes for physicians and hospitals that accurately describe the service? So are there existing codes that you can piggyback onto? Does the technology improve patient outcomes? That really goes towards coverage. And then lastly, does this coding and coverage allow for adequate payment? So do third-party payers provide competitive reimbursement that supports the manufacturer's price of the product? And again, I've had clients come to me and say, I'm fine. I have a code, I'm great. And just because you have a code doesn't mean you're covered. And just because you're covered by the insurer doesn't mean that payment is going to be adequate. So I don't want to scare you. I'm just saying, don't think, oh, phew, I have a code. I'm good. I'm done. You're not. And just to kind of look at all of the different influences on coverage decisions, there's a lot of them. Some of them, many of them are somewhat under your control, but not totally. So we talked right in the beginning about demonstrating unmet need, using peer-reviewed clinical literature if possible, professional society guidelines. You would like to have an advocate, hopefully a KOL that has influence within the professional society that has to do with your technology. It's a good idea if you can possibly get your technology discussed positively in the professional society guidelines. These and political forces will influence the payer to determine the coverage decision for your technology. And you won't be able to read this, but this is an example of a coverage policy from Anthem. And again, a lot of this is online. What is interesting is it's a wealth of information often. And I don't recall if this is a particular state, but I have an anecdote, a personal anecdote, where my sister-in-law was bemoaning the fact that her son had been denied coverage for a condition. What's the problem? Okay, let me look into it. It was a Blue Cross Blue Shield. I looked online. I found the coverage policy. It was very explicit. Now, it could be explicit coverage. It could be silent. It could be implicit non-coverage or explicit non-coverage online. But if you're lucky, it's explicit and says, particularly, as I mentioned before, what treatment guidelines are they citing? What references, published literature are they citing in support of their coverage policy? What types of lab tests do they expect and at what levels? What I found was that they were citing old treatment guidelines, old literature. There was new literature on the subject. I suggested that the pediatrician order new tests. And although he was borderline for some, he was actually right on target for some of the newer tests that we ordered. And ultimately, we were able to get my nephew covered. And that and the fact that insurers do not expect you to push back. Push back. 70 to 80% of the time, you will get a positive coverage evaluation if you push back. Now, you have to push back with evidence. You can't just say, oh, please, I think you should cover. You have clinicians in your that are writing letters, you cite literature, you say personally that this has helped me. I've seen this with physical therapy where they say, not blanket 30, that's it, 30 sessions, and then you're good. And I say, well, I can show you, my physical therapist can show you, the orthopedic surgeon can show you, blah, 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 that I have improved beyond the 30 sessions. Now, personally, it took me about 5 months, but I got the additional sessions and quite a few additional covered. So don't despair, personally, go forward and demonstrate with evidence that this coverage policy should be positive on your behalf. It works. And lastly, real quick, Medicare rates are really the standard. Commercial rates, and Kaiser Family Foundation, I don't know if you're familiar with them, but they are a fountain of information. So, and it's really well documented. So if you ever come across something that is cited through Kaiser Family Foundation, you can typically trust it. It's really well documented. But they've demonstrated that private payer rates average about 43% higher, so 143% of Medicare rates, and that Medicaid payment rates have stayed relatively constant at 70 to 90% that of Medicare. So again, Medicare is basically the standard. Commercial insurance pays greater, Medicaid pays less. And then just the last couple of minutes, one of the things that has really been useful in the pandemic was that it finally demonstrated that telemedicine, telehealth, it was really useful for patients that certainly are disabled, elderly, maybe in a rural area that don't have great access to in-person services, or just busy persons that really can often be covered using telemedicine. There are HCPCS and CPT codes that cover these. There's remote therapeutic monitoring, remote physiological monitoring, transition care management, chronic care management. And if you look at some of these reimbursement codes, and these are some of the most recent, you think, well, $61 for 20 minutes. But if it's an additional 20 minutes, that almost doubles the reimbursement. If it's complex, that's double, almost double. The non-complex, then you've got an additional 30 minutes in complex, then you've got $200 in reimbursement. So if you happen to have a technology that adheres to the tenet for monitoring and education, especially for telemedicine, it's worthwhile to consider using some of these codes to cover it. So that's in a nutshell, reimbursement in the United States, and happy to answer any questions.
Just wanted to say great talk, really good.
Thank you.
Maybe it's a logistics question. I know some other people who would be interested in this topic as well, colleagues of mine, but they're not direct Catalyze awardees. Are we allowed to share these slides and discuss with them, or is this just for us?
I don't know. That's a good question.
I think if it's okay with you, Renee, if your permission, I think that is okay to share.
Sure, absolutely.
Great.
Thank you. Very generous. I'm sure they'll find it interesting as I did.
Yeah, great.
And will we be getting the slides afterwards?
Yes, the slides will be posted on the Catalyze public website as well, and with the recordings. So we will let you know. We'll send an email out with all that information.
Thank you.
Hi, Renee. Dory Jones, thank you for the great content. Question about, in your experience, do you think that if we have a technology that could fit into a particular CPT code, but is nuanced and there's not a lot of coverage, sort of trying to get better utilization of a code, a more streamlined pathway than pursuing a new code?
Yes.
Okay.
Right. Yes. Yes.
It sounds intuitive, but I know there's a lot of,
And people think, oh, I'll just pursue a new code. It is not easy. It
yeah.
can take 3 to 5 years to get a new code. And so right away, I think you could tell that that's what I was going to say, that, even if it's nuanced, if you can determine that the evidence is more or less along the lines of, all right, it's not exactly this, but it's really close, then a lot of insurers will go for that.
Got it. Okay.
Yeah.
Thank you.
Yeah, sure, of course.
We still have about 9 more minutes. Do we have any other questions for Renee?
Hi Renee, I have a question. You talked about, kind of, if you need to get a new code, using some of those clinical outcomes to kind of help justify a new code. Um, I'm just wondering, do you see that kind of go hand in hand with the data that, you might need to present to the FDA, or is that kind of a separate subset? And I guess how do you plan for that? Can you meet with some of those, administration, CMS officials or people to kind of plan ahead and kind of know, what you need to show to them to, to justify a new code?
Yes, absolutely, you can. Especially if you have a device, and there are fast track mechanisms for devices that have specific coverage with evidence development pathways. And it is definitely worth it if you happen to, do you have a device by any chance or?
Yeah, ours is, well, yeah, our
Okay.
technology is a device rather
Okay,
than a drug.
so it's worth it to look into that and look at coverage with evidence development for a fast track device, just if you Google that, and they'll tell you a pathway, who to talk to specifically at CMS about that, because that's a CMS construct.
Perfect, thank you.
Sure, of course.
It looks like Dr. King has his hand raised.
Hi there. I had a question about how you work your way through the decision makers. So who are the first people to approach? And then what do those initial conversations look like in terms of coverage and adoption? I guess this is as much a coverage question as it is kind of a procurement question, which is sort of wrapped
Right.
up with reimbursement, of course.
Right. So, a lot of times I just have people start with, as I said, Googling, one of the Blue Cross plans or one of the plans that you're hoping to discuss your ideas with. And a lot of times they'll mention an initial contact for you. And that's often the way to start, because you can think, well, I'll look and see who the medical director is or whatever, but that might not be the right person. They might not be involved in the coverage policy. They'll, maybe do overarching, but they may not be the people that you would really want to approach. So it's worth it to do some of those landscape coverage determinations and figure out how you think you're going to be covered under what kind of policy, and then approach one of the people that is mentioned there. I wish I had a more specific idea for you, but it really depends on the technology. It depends on what you're trying to do with it.
Is that similar for procurement? Like when you're adoption?
I would say yes. Yeah.
Dr.
Okay.
Higgins? Sorry. Yeah.
Hi, yeah, thanks for very interesting discussion talk. I'm wondering if in the area of in vitro diagnostics, it seems like reimbursement has particular challenges, and it's often difficult even to find sort of good roadmaps, good proofs of concept. Some new in vitro diagnostics that appear to have achieved some market penetrance and are reimbursed. It's hard to figure out what evidence they use to get to that point. And I'm just wondering if you have any suggestions on finding those good examples. Where can we find examples of in vitro diagnostics that have recently been introduced and that have achieved success. Yeah.
So one of the things I can say is that the seed program has developed, and it should be on the seed, and maybe Kathy would even know, on the seed website. They've got in vitro diagnostics, and since you specifically mentioned that, are you familiar with that document? And it's like a back and forth, very interesting format, back and forth questions. Well, I know about this, how about that? Or well, how about this? Well, how do I go about doing this? And it answers very specific questions about in vitro diagnostics. And it talks a lot about clinical utility, when I mentioned is really important as well.
Great, I'll check that out. Thanks.
Yeah, and I can try and find that document for you and pop it in the chat.
Thank you.
Looks like we have about 4 more minutes before we wrap up this session. I want to just say thank you again so much, Renee, for your presentation. It was wonderful, and for everybody's joining the call.
Yeah, thanks so much, everybody. You're welcome, Carol. My pleasure.
Do we go back to the room, or how do we do that main room?
They will transition us back to the full room in just a couple of minutes here, or a few minutes. But feel free, if you'd like to go on mute and turn your video off, it's totally fine while we're waiting.
Thanks, Anna. I appreciate it.